Hi, Harold. How are you?
I'm doing well, Steve. Nice to see you.
Likewise, likewise. Thanks again for agreeing to participate on the Beating Melanoma project. And I first want to introduce you. This is Harold, Dr. Harold Rabinovitz, who is a board-certified dermatologist. He's also a Mohs surgeon. He's been practicing, I would say, dermatology specifically focused on skin cancer for almost 35 years, more than 35 years. And you've been a professor, not prof you received your medical degrees at University of Miami, and you served as a voluntary clinical professor at University of Miami, and also a professor of dermatology teaching at Medical College of Georgia. And welcome.
Thank you.
So, Harold, to get started, and you've done so much in this field, and you've taught so many different folks. And what makes you really unique is you are not only a dermatological surgeon, but you have really, really sort of pioneered a lot of the early detection technology. And just sort of talk about a little bit about what type of tools that you use at this point, technology that you use that help you to detect melanoma skin cancer at a very early stage.
So the most important tool is my eye. I evaluate patients clinically with visual inspection, but unfortunately my eye is not so good. And when I have a pigmented lesion, which is either an atypical mole or perhaps even early melanoma, my accuracy is about 60%, which is like going to Las Vegas to play blackjack. So over the years, we've used other tools. The most important tool we use is called a dermatoscope. It's our stethoscope of the skin. It's a handheld microscope, and when you place alcohol on the skin and you place this scope on the skin, you can see patterns that you can't see with your eye, and these patterns can be seen not only in the epidermis, but also at the dermal epidermal junction. And based on these patterns, our 60% now goes to about 80%. So now I have a chance to beat the Las Vegas card players.
I think you're being modest. I would say, I agree with you. Some of the study have shown that just by clinical examination alone, the dermatologist accuracy is about 64%. So you bumped it up to 80%. So your odds is a little bit better. What else do you use?
We use another instrument called the confocal microscope. It's a much larger instrument. It's actually a laser beam, which when it hits the skin gets reflected back into a computer screen where you see the layers of the skin live. It's almost like virtual pathology. When I send tissue to the pathologist, that is to do a biopsy, and I'm concerned that it might be a skin cancer, a melanoma, he actually only looks at about 2% of the lesion. With confocal microscopy, we're looking at 100% of the lesion. We're looking at it in a different plane. When it's sent to the pathologist, he looks at it in a vertical plane, whereas we look at it in a horizontal plane. And the accuracy is quite good. It bumps my 80% up into the 90s and is another tool which we use. The main problem with the confocal microscope is it's a relatively larger machine. It's difficult to get in certain areas, as well as it's time consuming. It takes a good 15 to 20 to 25 minutes to evaluate a single lesion.
That's a long time.
It is a long time. But for selective lesions, in my opinion, it's the Rolls Royce.
So where would you use, I think for those out there who do not know about you, you've been doing dermoscopy, you taught all those people about dermoscopy around the world, and you run all those textbooks. For you to come out to say, dermoscopy is not good enough and you use confocal laser microscopy, but where would you use it? I mean, how do you deploy this in your clinical practice?
So, in my opinion, the best usage is for isolated pigmented lesions on the face.
Agree. Yeah.
That is, we know that for a lesion, which is a brown flat patch, we have a differential clinically. The differential includes a lentigo, a seborrheic keratosis, a pigmented actinic keratosis, a lichen planus-like keratosis, and then melanoma on sun-damaged skin. And with the dermatoscope, we can always bring it down to maybe 2 or 3 diagnoses. Our differential diagnosis with the dermatoscope is usually between a pigmented actinic keratosis and a melanoma in situ. With confocal microscopy, it's a real game changer. That is, we can make a diagnosis almost all the time for these melanomas on sun-damaged skin with the confocal microscope. The other use of the confocal microscope for pigmented lesions, particularly melanomas, are when you have equivocal lesions, you're not sure whether it's just an atypical mole, a congenital mole with unusual features versus a melanoma. Well, there are patterns that we can see with confocal which help us distinguish the two. And in those instances, it's quite useful. Confocal is also useful not only for melanomas, but for other neoplasms of the skin, for basal cell carcinomas, for squamous cell carcinomas. So it's a very useful tool for selective lesions and in selective locations.
Yeah, I mean, I think one of the challenges you mentioned, not only it takes a long time, it's expensive, and plus, you really have to know how to use it, right? Just like dermoscopy, if someone just picked up the dermoscope, didn't really know how to use it, the diagnostic accuracy actually goes down. But I would imagine confocal laser microscopy is the same thing, basically.
It is. I mean, the language, it's a specific language. And once you learn the language, it's actually easier than dermoscopy because there are fewer things that you have to know.
Yeah, no, I agree with you, especially on the facial lesions, especially for looking at lentigo maligna. It's very, very useful. And also, this is a really great place because most people don't want to have a biopsy on the face if they can avoid it.
Yeah.
No, I know at one point that you use a lot of total body photography. How does that come into play? And like in what selected patient do you use total body photography?
So we use full body photography for individuals who have numerous moles of different sizes and shape, who also have a history of melanoma. We use it for individuals who are concerned that they're going to get another melanoma. And basically, I try to explain to the patient that some people need family albums, other people need mole albums. So the use of full body photography is just a baseline. So when a patient comes back in, if he's concerned about a particular spot, and I now have used dermoscopy, and I can tell the patient, it looks fine, but let's go back to your baseline set of photographs to see if there's really been a change. We also use it the same way that if there's something that concerns me, I now have a baseline to compare it to. And that's the main use of full body photography for me. I don't image every single lesion with dermoscopy, which is called mole mapping. We might do selective lesions. So the way we normally use full body photography is for high-risk patients, patients who are concerned, patients who have lots of moles of different sizes and shape, and patients who sometimes just need a little extra in terms of making them feel comfortable.
Who are those patients? Do you have any criteria, like number of moles or history of melanomas or?
History of melanoma is one of the most important reasons why we do full body photography. Individuals who have lots of moles of different sizes and shape, lesions that I have trouble with in terms of when I'm looking at them and say, there are many of these nevi which concern me. And rather than do a biopsy, it's better just to follow these both with our clinical exam, full body photography, as well as with dermoscopy.
I'm gonna pin you down a little bit because all this, the audience we have a general public, and you say a lot of moles. Do you have a number that you cut off? Like say 30, 40, 50, 100? Is there a number?
Sure. So there really isn't a number because if I have a patient who has hundreds of small moles that look all normal in their size, shape, and color, I wouldn't do full body photography.
Okay.
If I have a patient who has many moles, greater than 30 moles, and the moles are all different types of patterns, that is an individual who I might consider using full body photography. Most individuals have what we call signature nevi. That is, their nevi patterns, even with our eye, they look similar. So we look for outliers. Now, if someone has 3 or 4 patterns that are all outliers, these are individuals who are best followed with full body photography.
Yeah, that makes perfect sense. I do the same, obviously. No, I'm gonna push you a little bit. So you already sort of alluded to it a little bit. When you say patterns, do you mean the clinical patterns, or do you mean the dermoscopy pattern, this pattern that you see in the dermoscope?
Both.
Both.
That
Okay.
is, yeah. So there are individuals who have flat pigmented lesions, and that's their pattern. Okay. There are individuals who have lesions that are raised and mammillated. That is, they have a pebbly surface. It's a different pattern. Those are the patterns we see with congenital nevi or moles at birth, or nevi with congenital-like features. We have individuals who have patterns where many of their moles have asymmetry and irregular borders, but many of their lesions have this pattern as opposed to one specific lesion. So we look at the patterns clinically, and then we look at the patterns dermoscopically. And the patterns dermoscopically as well, most individuals have signature patterns with dermoscopy, and we look for outliers with those as well.
So we talked a lot, right? We talked about you do a clinical exam, you do dermoscopy, and you do total body photography doing confocal. And you've sort of involved very early on in some of the artificial intelligence in detecting skin cancer, maybe 15, 20 years ago. You've always involved in technology. What is around the corner?
I believe that artificial intelligence is around the corner. There are some individuals who are doing work in this area where they're getting good numbers in terms of what we call sensitivities and specificities. And I believe that probably within the next year or 2 years, that some of these will be approved by the FDA for use for evaluating patients for pigmented lesions, as well as non-pigmented lesions, that is for skin cancers in general.
No, I think those will be a game changers, because I think not everyone will have access to someone like you, right? And by having those AI, I know that we're actually going to talk to some other folks and some AI experts and focus on this. Now, shifting gears a little bit, you practice in South Florida, and there's a lot of sun exposure down there. And what do you see? Do you sense that the background skin is so sun damaged compared to, let's say, I was at one point in New Jersey, the skin is not so damaged. And like, I think to me, it's really difficult sometimes to tell those lentigo maligna. And how do you go about that to differentiate this?
So not all melanomas are the same. That is, we've learned that different melanomas have different gene mutations. And melanomas that we see quite often in South Florida are due to sun, but they're more an age-related problem. That is, these melanomas that we see in older individuals, we call them melanomas on sun-damaged skin, but they're particularly most common in our older population. So whether it's truly just sun-related, they do have distinct patterns. And usually with these types of lesions, we look for clinical clues. We look for the clinical clue of the color gray, and then we look for the dermoscopy clues, and they have distinct patterns as well. So by doing this, we're really able to separate out these early melanomas from just someone's sun-damaged skin from what we call age spots or solar lentiginous.
I think one other thing, I think that the folks out there should really sort of start to appreciate is the fact that, like exactly said, not all melanoma are the same, right? So those early lentigo malignant melanomas, those melanoma in situ, to me, they're very indolent, right? Once you remove it, they're gone. The risk of their spreading to the rest of the body is very, very low, right? And so I think a lot of people out there, once they hear the word melanoma, they get terrified. But everything you described, those kind of melanomas, they don't usually do much of harm.
Yeah, so these melanomas in our older patients with these melanomas on sun-damaged skin. They do have high cure rates, and they're very slow growing. That is, some of these individuals will have these flat patches of skin, which are actually early melanomas, for many, many months to sometimes years, in contrast to some of the other melanomas. Some melanomas are what we call de novo, where they just pop up on the skin. Some melanomas are associated with a previously existing mole. So they're all different types of melanomas. And then we have a type of melanoma, which is actually a shades of pink melanoma. We call these the pink panthers. That is, they're very, very difficult to diagnose. In those instances, we again also look for the dermoscopy clues because they too have a distinct pattern.
Yeah, I think that's the thing. This is one of those most difficult melanomas to diagnose, the pink melanomas. And the pink melanomas, there's just very little dermoscopic clues sometimes. And they're, the pink panthers, the mimickers, and very difficult. Couple of things. Coming back to the lentigo maligna, because this is really a unique type of melanoma that's not commonly sort of seen. The treatment for it is obviously surgery. And what do you recommend for patients when surgery is not an option? Either the patient is too frail or it is the tumor is too big.
So the overwhelming majority of melanomas on sun-damaged skin, in my opinion, Mohs surgery is the treatment of choice. And that's in the overwhelming majority. There are very few of these melanomas, at least in 2022, which can't be treated surgically. There are selective instances, however, where you can't. And in those instances, most of those types of cases, some individuals will use imiquimod, which is one of the medications which is used actually for basal cell carcinomas. And in a selective individuals, we might use that. Radiation therapy has been used in the past, but for the most part, I still believe that almost all melanomas on sun-damaged skin can be treated surgically. Now, the problem with treating these with your conventional surgical excisions is that high recurrences with a standard excision, it reaches almost 20%. And that's why Mohs surgery, in my opinion, is the method of choice for these types of lesions, particularly on the face.
Yeah, totally agree. And I think the facial, I think we using the word Mohs surgery, and I think one caveat to add is you definitely really need special MALT1 stain or immunostain. Otherwise, it's sometimes a little bit challenging to tell the difference between real melanoma cells versus the artifacts from the freezing, right? And in some other places that if you don't do Mohs, they do those kind of slow Mohs, meaning that they remove the cancer and then they send the rim of tissue to the pathologist and get permanent sections and look at it to make sure the margin is clear before doing the repair, in essence.
And so that's the other alternative other than doing Mohs surgery is, as what you mentioned, slow Mohs. And basically what you're doing is you're
Margin control, yeah.
You're surgically removing the melanoma and you're getting what are called rush permanents, where you have your pathologist have the tissue back to you within a 24-hour period where he's looking at the entire skin edge and you're doing Mohs surgery in terms of looking at the entire skin edge on a 24-hour basis, as opposed to all in one sitting.
So coming back, shifting gears a little bit, moving away from lentigo melanoma, and we touched a little bit about the pink nodules. Those are pink melanomas. Those are very, very difficult to diagnose. We talked about lentigo melanoma on the face, are very difficult to diagnose. We talked about the pink lesion to be very difficult to diagnose. Are there any other difficult lesions, like acral side, nail side, or any other body side that's difficult?
So the other type of melanomas we have are what are called acral lentiginous melanomas, melanomas on the soles. And those melanomas are also difficult to diagnose. They too have a distinct pattern dermoscopically. We see that in individuals who have much darker pigment. And it's very, very important to realize that individuals with very dark pigment, individuals who are Fitzpatrick 5 or 6, these individuals, it's very important to look at the bottom of their feet because this is where they get melanomas. It's the most common melanoma that we see in those types of individuals. In fact, in Mexico, it's the most common melanoma is an acrolentigenous melanoma, which is surprising to me. And it's also difficult to diagnose not only clinically, because with very, very dark skin, some individuals have numerous brown patches of skin on the bottom of their feet, and you scratch your head because is this just normal for this individual? Or could this be a melanoma blending in with these other areas of just flat brown patches of skin? And dermoscopically, it's difficult as well, because a large percent of these don't have the classic dermoscopic pattern of we call the parallel ridge pattern.
So, what about confocal? I guess confocal cannot reach because the epidermis is too thick.
It's too thick. Yeah, and also the machine is too big.
Yeah.
That is, there are two types of confocal. There's a handheld, but you're only looking at almost a millimeter area of skin. It's like doing a 1 millimeter punch biopsy for a big lesion. Okay, you're not going to get much because when we look at pathology, when we look at confocal microscopy, we're looking at the overall pattern. And in order to really evaluate lesions, we need to have the entire architectural pattern.
So shifting gears a little bit. So everything we talked about, the acral lesion, everything talked about, this is mainly for people who, the difficulty is for people who are Hispanic origin,
Yes.
African American,
Asian.
Asian, exactly. And of course that we have to include that Caucasians also can get those melanoma on the bottom.
They can.
But exactly like you said, because a lot of those, Asians, Hispanics, and African American, they can have those benign pigmentations, right? And that's what's sort of making it difficult to tell what is a real melanoma versus just benign pigmentations, basically.
Correct.
So a couple other questions. You've been doing this for 35 years, more than 35 years. You got a lot of wisdoms, everything else. What do you tell your patients who first get diagnosed with melanoma?
Well, first of all, it depends on how thick the melanoma is. If it's a very early melanoma, a melanoma, which we call in situ, confined to the epidermis, or a thin melanoma, I just explained to them that all that needs to be done is this just needs to be surgically removed. And the cure rates are very, very high. And then we have our melanomas, which are a little deeper. In those instances, I tell them that the cure rates are very, very good, but sometimes you need to have some additional procedures. But the important thing to remember is that we have come such a long ways, not only with the removal of melanomas, but also in terms of the treatment, especially if you have a very, very invasive melanoma. That is, it's a new paradigm in terms of how we manage melanomas for individuals who have extensive melanomas as opposed to these very, very early superficial lesions.
Yeah, you're right on. I mean, I think we talked about the lentigo maligna, right? The cure rate is almost 100%, once you remove it. The stage 1 melanoma, it's always high as a 98%, 5 to 10 year survival. You mentioned all this newer immunotherapy. In fact, I'm not sure if you saw the news release. They're talking about the combination of, I believe it's Keytruda plus Moderna's virus, oncolytic.
Yes,
Not oncolytic. Yeah. So it's amazing. So I mean, we are doing this Beating Melanoma project, this book and web, and every day, you need to update this stuff. So last question. So for those of you who do not know, Harold is actually one of the world's really, really talented dermatologist and a technologist, dermoscopist, but he also has a great talent. He's a great tennis player. And in fact, he beat Jimmy Connor and won your junior national tennis match.
No, Close,
Close,
but
okay.
well, it was in the 14 unders. It was the Junior Orange Bowl. It was doubles.
Doubles, got it.
It was Eddie Dibbs and myself against Jimmy Connors and Brian Gottfried.
So the bottom line is you're a great tennis player, always playing
Was-
this game in South Florida. Why is it that your skin looks so good? What do you do? Like, how do you protect yourself?
Well, I use sunscreens. I wear a hat, and it's genetics. Good genes.
But you're doing this religiously every day and going
Well,
out
I
to
don't,
this.
well, I don't play tennis every day anymore, but when I did growing up, I probably didn't use sunscreens the way I would have if I had been educated and had known better. But part of it is also just being lucky. I do take medications which reduce areas of sun damage, precancers, by taking niacinamide, which is over the counter. And I try to use my sunscreens and protect myself whenever possible.
What else do you do? What other magic tricks you have? I won't tell everyone how old you are, but they are going to be very envious. But the most amazing thing is that you live down in Florida. Every time I see you, every year I've seen you, never had a sunburn, and you don't age as fast, not that much wrinkles. And we know UV radiation does wreak havoc on the skin. What are your other secrets?
There are none. I use you can always use protective clothing. I tend to just use sunscreens and wear a hat and protect myself as much as possible. I mean, obviously, you want to if you're going to be playing tennis, you want to go early in the morning, late in the afternoon. You don't want to play in the midday where the ultraviolet exposure is greatest. But I think that it's just much of what we do has to be common sense.
Common sense it is. Any last advice for people who are listening to this video about melanoma that you would like to share?
Only that if you develop a melanoma, don't be afraid. Just go through the process in terms of having it correctly managed.
Very wise. Thanks, my friend.
Be well. You take care.
All right. Thanks again for doing this. Bye.
My pleasure. Bye.